Namaste, my name is Kavitha Murthi and I'm an Indian occupational therapist. Today I'm presenting on the topic flowing through the Indian land, Kawa in India. This is essentially my professional journey through my undergraduate and postgraduate years. Before I begin, I would like to mention the special efforts of Mr. Srinivasan Iyer for his creative inputs and helping me throughout this presentation. What I intend to do, hopefully in the next 10 to 15 minutes, is to give you a gist about occupational therapy in India. I would be using the acronym OT for occupational therapy throughout my slides. The need for conceptual models in the Indian context and use of models in Indian practice, culture and conceptual models, and my experience of using Kawa in India, which is essentially a short film. Before starting to talk about occupational therapy in the Indian setting, I would like to give you a small gist about how the Indian medical and allied healthcare system works in India. India has both government and private healthcare systems. Privatization is gaining importance rapidly within the Indian climate. Now, to talk about the history of occupational therapy, OT was first developed by Kamla V. Nimkar, a social activist who studied occupational therapy in Philadelphia School of OT and brought back the principles to India and embedded it within an hospital setting. She chose King Edward Memorial Hospital to start OT services, after which there has been growing demand, and this helped proliferation of OT within prominent branches of allied healthcare like mental health, pediatrics, neurology, cardiology, orthopedics, etc. After that brief description about healthcare in the Indian context, now I would like to start talking about the current stance of occupational therapy in the Indian ethos. As mentioned by Karthik in his book in 2011, occupational therapy is yet to make a national mark in Indian allied health system. This is because occupational therapy is not recognized in major healthcare policies like Mental Health Act of 1993, Person with Disabilities Act 1995, Rehab Council Act of 1992, and the National Trust Act in 1992. These policies chiefly advise the disability management and rehabilitation within the Indian context. So this is really alarming that occupational therapy services have not yet been mentioned within this policies and paradigm. Moreover, Indian healthcare system is still adopting the medical model of care, which is extremely reductionist and views an individual through performance areas, performance deficits, and performance components as mentioned by Turpin and Ivama. Apart from this, it is also alarming to see that occupational therapy journals and archives do not have studies which focus on underpinning rationale, that is, why a particular intervention is used or what was used within a particular area, or any evidence as to what and how therapists thought through the process of occupational therapy for a particular individual. Despite 57 studies in the past 5 years focusing on interventional effectiveness, there was not even one single study which focused on underpinning rationale or scaffolding which supported OT practice within the Indian context. Therefore, as pointed out by Hammel, maybe Indian OT practice is still based on tacit knowledge or guesswork. As we saw in the previous slide, since there was no focus on underpinning rationale as to what has to be used where, it is even more important to maintain Indian occupational therapy around the central core tenet of occupation, which is why, and since this is not there, there is professional role blurring as noted by Wilding and Whitefoot in 2007. It is in my personal experience that even I have been referred to with an array of terms like physiotherapist, nurse, doctors, arts and crafts teachers, because the contribution that I do in a multidisciplinary team is not yet clear. This is my understanding, and this is also supported by the scaffolding provided by Fortune in 2000, who mentioned that if there is not a particular boundary for a particular profession, then such professions could be termed as technicalities, as there would be encroachment from other professions, and that is why occupational therapists are sometimes termed as gap fillers. Legitimate gap filling is present in each and every profession. However, it is also very prudent to notice that occupational therapy in the Indian context is slightly losing its identity. When I was working upon conceptual models and occupational therapy practice, I found that culture plays a very crucial role in scaffolding both occupational therapy practice as well as conceptual models. It is very crucial to understand the uniqueness and the impact that culture has on conceptual models. Culture can be described as an individual and personal representation of oneself, as mentioned by Dr. Ivama. So it is highly unique and personal, and it is also crucial to understand the impact of culture upon disability. Within the Indian context, there are still some sectors which consider disability as a stigma, as a curse, and also as an evil eye. So it is very important to work around these values when using conceptual models or transporting conceptual models from different values. When I realized the importance of culture in occupational therapy practice, I also decided to sort of put up like a distinction between the Western values and the Eastern values, just to make my understanding on this topic a little bit more clearer. When I looked into the Western values, especially derived from models like the model of human occupation, the Canadian model of occupational performance and engagement, and person, environment and occupation model, I found that stress was placed on autonomy and independence. This is sort of like a non-understanding component in the Eastern culture, as service users in the East consider themselves to be inseparable from the environment, just to maintain a very harmonious relationship between themselves and the surrounding environment in which they are living. So the second point, that is mastery over the surrounding environment, does not essentially hold true in the Eastern culture, because Indians try to maintain a very stable relationship within their environment. That is, they place an importance not on their personal aspirations, but on the stability of the relationship between themselves and the environment. The third point that was mentioned and highlighted was client-centered practice. Whereas this is really important even in the Eastern culture, importance has to be equally placed on the values of family and society, as family and society play a very important role in caring for a service user or an individual. The fourth point was occupational engagement, where occupational therapists have to select and implement occupations which have a personal positive meaning for the service user they are working with. This is not essentially true, because many individuals in the Indian culture, Indian society, are not participating in occupations that are giving them any positive meaning. Some groups I can think of are Indian service users who come to me who are from the begging class, who use begging as a mainstay for work, and women who come from the red light areas, as we call it, who are prostitutes and who are a part of human trafficking. It is very difficult for me to understand occupational engagement with such populations. And the final point is classification of occupation into self-care, productivity and leisure. As Hammel mentioned in 2009, is sort of like an oversimplistic division of occupations. In the East, essentially, caring for elders, caring for dependents, participating in cultural and societal occupations which do not necessarily fall into any of these three classifications. Collating all the evidence that I showed to you in the slides above, I would like to point out that culture plays a very crucial role on conceptual models as well as on the OT practice in the Indian context. So therefore, direct transportation of Western philosophies within the Indian context could be catastrophic, and it could more so lead to a square peg in a round hole phenomenon. Apart from this, limited adaptability, that is conceptual models, even though having a margin of flexibility, have a rigidity after a point of view, and hence it has to be prudently treaded upon and carefully exported from one culture to another. If this is not done, then use of such models and frames of references could create confusion, disengagement, dissatisfaction, coercion and alienation, as pointed out by Ivama. Having wrapped up all this and hopefully given you a view about OT practice in the Indian context, I would now like to take you through my personal journey of the Kawa model. I used Kawa with one of my service users, an amazing lady called Rita, and now you would see a sort of like a small movie clipping where she introduces herself and a small interview between me and Rita, and finally her take on the Kawa. Thank you.